Today we have our second talk. The topic is language and basic terminologies in pathology, why and how to describe. We have with us as chairperson Dr. Anita Borges ma'am, who is a lab director and pathologist in Mumbai. So the talk will be delivered by Dr. Siddhartha Datta Gupta sir. He is the emeritus prof in NAMS and adjunct prof in the Department of Pathology in St. John's Medical College, and he is a retired dean and prof in AIMS New Delhi. So we have students with us, Nirmal Thomas, Dr. Nisha Patel from Bikaner, Jinal Sasaya from BJMC Ahmedabad. We have with us Seema Kumari. She is from Patna. We have with us Dharti Patel from Surat, Aditya Jaiswal from MP, and Anupam from Prayagraj. So we have our upcoming slide seminar on a very important topic, that is on patterns in pathology, and it will be taken by Dr. Anita Borges ma'am. So myself, Bonita, and along with Dr. Sakshi Gupta, we are moderating the session. Our webinar hosts are Dr. Anita Borges ma'am and Dr. Sumit Gujral sir. There's a few reminders for the session. Please do not send any annotation to the presenter. We have few disclaimers of the program. Kindly have a look. So now I welcome Siddhartha sir to the podium. Hello, sir.
Hello. Thank you. Can you hear me?
Yes, sir. Yes,
Okay.
sir.
Yes, sir.
Yes, sir.
Thank you. I'll share. I would like to thank Madam Dr. Anita Borges and Dr. Sumit Gujral for this opportunity. And this is something wonderful they've been doing for years. And it's absolutely priceless. And it's an honor to be with them, taking one or two of these webinars. And this webinar that I'll be taking is on terminologies in pathology. Can you see the slide?
Yes, sir.
Yeah, okay.
Yes, sir.
This is something which you take every year, and it hopefully it'll give an inkling of what terms to use, because pathology is quite a descriptive subject. So these are my disclaimers, and that's already there. So now you see, you must have heard the beautiful lecture by ma'am yesterday, previously. And the word pathology comes from pathologia, and it means the study of suffering, or actually it means study of diseases. As a medical student, we often wonder what subject to take. And this is by somebody who was in immense, he gave a wonderful description of how to choose your subject. So if you're crazy, it depends on your attention span. And if it is significant, you take psychiatry. That was the subject. If it is non-existent, you can take emergency medicine. If you are sane and hardworking, then of course, it depends whether it's not so much or, sorry, then if you're afraid of the dark or afraid of light, if you're afraid of light, you take radiology, and you're afraid of dark and think big, you take dermatology, think small, you take ophthalmology. If you're very hardworking, it depends on your attitude. If it is mean, you take surgery. If it is nice, And you hate adult, you take pediatrics. If you hate children, take medicine. And if it doesn't matter if the patient is asleep, take anesthesia. The patient is dead, you take pathology. This is what he told. And we had a good laugh. And but pathology is now less of the dead, although the dead teaches the living. So now in pathology, unfortunately, we have a lot of descriptions to do. And sometimes we just use them without knowing what it is. So whatever terms we use, whatever things we use, it goes by convention. And it's good to know what is the origin of the term because, like it's different in different connotations. Like the word excel in Latin, they are consonants, and in Roman, they mean 40, 50, and 10 less, 40. But then if you go to a garment shop, excel means a different size. So this is just a guide for the postgraduate students. And as you use these words more, you'll know more and more about this. You see, in pathology, we use different ways of diagnosis. Suppose a patient has fever and dysuria, and you give uh, appropriate antibiotic, even empirically. And if the patient is cured, well, the diagnosis is an urinary tract infection, whether or not you have a microbiological proof, right? So similarly in pathology, you see a granuloma that's AFB negative, but still you think it's tuberculosis. They give ATT and the patient is cured, it's still tuberculosis, right? So whether there's no proof that you haven't shown a mycobacterium there, so you presume this is tuberculosis. And of course, if you have a culture, PCR, etc., so on and so forth, right? So this is a granuloma like any of this. So this is a heuristic analysis, where the end justifies the means or whatever you want to say it. The other way is you see a granuloma, then you go step by step. Well, is it confident or is it discrete? Is there necrosis or not? And then you do an AFB. So that's a pattern analysis, and that's important. Anyway, you'll learn more about this later on. So the first one is the payoff. So diagnosis is justified by the end result of treatment. In heuristic, you ask certain questions, and then in the pattern recognition, it's based on the overall form rather than just individual features. And as you become more and more experienced, you'll just put a slide down there, you see the pattern, and immediately the diagnosis comes almost from the spinal level. It's so fast, right? So, but it's better to make a clinico-pathological correlation always. See the slides without the diagnosis or any history. Try to find out the findings and go back, and from the findings you build a clinical history and then you make a diagnosis. You see, if you do this day in, day out, it is a slow process, but you learn a lot, right? But whenever you are doing whatever way you see slides or do anything, they expect that pathologists and radiologists give a report with description. And that description should be understood by the clinician. And you have to be short but convey everything in those. So those terminologies that you use is very important. Now the fixed cells, so now the dynamic, sorry, can I just push it down? Okay, right, yeah. So now we'll come to some of these terms that we use. One term that we use is active. Now, can we use the term active in histopathology where cells are fixed, they are not in a dynamic state, whereas activity actually means something that's dynamic, that's going on. And so logically, this may be incorrect. But anyway, we use the term active in certain non-neoplastic as well as neoplastic lesions. For example, piecemeal necrosis of the liver, we say it's a chronic hepatitis. Earlier, the term was chronic active hepatitis. And the clinicians will always ask you, is there piecemeal necrosis called interface hepatitis? Actually, is there interface hepatitis or not? And this is a part of grading of hepatitis. Then you say an inflammation is active when there's a lot of neutrophils. For example, in the glomerulus, in proliferative or glomerular nephritis, they say, what's the activity? Is it very active or not? The clinician will ask you. Similarly, is the colitis active or not? So you find neutrophils. So generally, in non-neoplastic lesions, it's either inflammation, um, nibbling into cells and destroying them, and invariably it's because of neutrophils. It's an acute inflammation like that. So you have active hepatitis, active glomerulonephritis, active colitis. In neoplastic lesions, on the other hand, when you use the word active, it generally refers to brisk mitosis. And the mitotic index is used synonymously. And it's, although nowadays everyone, most guidelines suggest you indicate the number of mitosis per unit area or a specific area rather than just the field and so on and so forth. So in neoplastic lesions, it refers to mitosis. In non-neoplastic lesions, it refers mainly to the inflammation that is going on, right? Not the healing part of the inflammatory process. So here you see, this is the interface hepatitis. So this is an active hepatitis. This is active colitis with neutrophils in the crypts, right? And this is a crypt abscess. And this is an active tumor, you can call it, with numerous brisk mitosis, right? So this is used. Generally, it's better to stick to the terms, this, although they say mitotically active and so on and so forth. It depends on how you convey the term to the clinician. You can give the mitotic index or number of mitosis per unit area or hyper filled and so on and so forth. The next with A will come to adenoid cystic. Now, adenoid cystic pattern is seen in many tumors, while describing, but it's the earliest one and the best prototype or the classical one is in the adenoid cystic carcinoma of the salivary glands. So this pattern resembles what is called the cribriform pattern, and one can mistake one for the other. And the cribriform pattern is characteristically seen in some of the breast lesions. So now in adenoid cystic carcinoma, remember there are two cells. One is the larger hypochromatic myoepithelial cells and the smaller real actual epithelial cells which have a little lighter staining nucleus with or without nucleolus. On the other hand, the cribriform carcinomas are made up of monomorphic epithelial cells, right? Here you'll find, so this is adenoid cystic, two types of cells, whereas here there's only one type of cell. So this is mainly formed from ducts. So you have the myepithelial layer and the epithelial layer. Here this is the cribriform, mainly epithelial cell. Okay. Now the spaces in cribriform actually real, but here these spaces are actually invaginations of the stroma. See, and therefore, you look at the edge of the tumor and you'll find the stroma going inside, So this tells you this is adenoid cystic. And the rest are all cut across. And in fact, somewhere, if you're lucky, you'll find these little eosinophilic stromal elements inside. Otherwise, you may or may not see. And look at the edge of the tumor. You see this stroma going in beautifully into the tumor, and then it cups in actually, and like a cup, and therefore, when you cut across, it looks round. Okay, so this is the adenoid cystic pattern that you get. And look, it's almost like a tubule, no? You'll have two types of cells and so on and so forth. This is the cribriform pattern. You have monomorphic one type of cell with punched out. Okay, right? Now, the word anaplasia. Anaplasia means going back or reverting to a more primitive type. Whereas undifferentiated means it is not differentiating or it's going forward. So it's not going forward. So it is like a car. Anaplasia is going in the reverse gear, whereas in the undifferentiated, the gear doesn't, gear shaft doesn't sit properly and therefore it doesn't move. So something like that, it's not differentiating. So, but many times you often use them together, right? So anaplasia would be going back. Undifferentiated means it remains here, somewhere here. So ultimately, if it goes back and remains here, it looks almost undifferentiated. The words look almost similar, right? So this is how it's used. So now this is differentiation from first MBBS to final year. If you don't progress, that means it's undifferentiated. But supposing you get demoted, then it becomes anaplasia. That's what it means, basically means. Now let us see. There are these tumors. One looks like this, one looks like this, right? Now this is invariably called anaplastic and one is called undifferentiated, right? So they are used interchangeably because you're seeing in a slide a single point. You're not seeing something progressing or regressing and so on and so forth. But by convention, anaplastic carcinoma you use in lung or thyroid, right? But many people suggest that why don't you call it small cell undifferentiated or undifferentiated carcinoma of the lung? So finally, it was more or less by convention. Nowadays, we use anaplasia to nuclear changes. That is hyperchromasia, post-clump chromatin, irregular nuclei or nucleoli. Whereas differentiation you use for the cytoplasmic features. So a small cell carcinoma of the lung will be anaplastic because of the nuclear features, but not undifferentiated, right? Because of the cytoplasmic features. Whereas anaplasia in Wilms tumor is purely based on these nuclear changes, right? So anaplasia nowadays is restricted to nuclear changes. Differentiation is used for cytoplasmic features. So that's how it is. Okay. Now you see these tumors, right? So the nuclear morphology will tell you it's anaplastic or not. And the cytoplasmic will tell you it's undifferentiated or not. Now there are two thyroid tumors. Just remember, one is the poorly differentiated thyroid carcinoma, and other is the undifferentiated or anaplastic thyroid carcinoma. You see here, they are used almost synonymously, and they have some differences. Like, for example, the poorly differentiated one have a diffuse nuclear positive for TTF1, and the anaplastic one is almost TTF1 negative. So that's the nuclear thing. And you get a frequent dot-like pattern for thyroglobulin, whereas invariably thyroglobulin negative. So although they look alike, here immunohistochemistry helps, in nowadays as we are progressing more and more, other ancillary techniques are used for uh, helping in the nomenclature of terminology. Immunohistochemistry now more and more molecular is coming, especially in the central nervous system tumors as well as in the lymphomas. Right. Next, we come in the Azzopardi effect or Azzopardi phenomenon, was given by John G. Azzopardi. He was also a very good breast pathologist, all of you should know. And this was mainly in the lung tumors, where there's necrosis and this bluish hematoxyphil concretion found, which are found around the blood vessels. So this is called the Azzopardi effect and seen the small cell carcinomas usually. And invariably search for them in the necrotic area. They become more prominent because of the contrast in the two colors. You can get them. So, right. Just like Azzopardi effect, you have these dark bodies, but they are not around blood vessels. They are almost like smudged nuclei, you know, and this is called the hematoxylin bodies, or some people call it hematoxyphil bodies, and they're typical of SLE. Just like you get in SLE, nowadays, of course, you do ANA and other things, but earlier you'd see smudged nuclei, especially there are certain tests in which the blood smears were studied and you could find the smudged nucleus. They're nothing but these DNA or nuclear material which gets smudged out, and they are called hematoxyphil bodies. Right? You're seeing this in also in the kidney in a lupus nephritis. This is in the spleen, and then you can get it in the heart in verrucous endocarditis and so on. So then you have the term amianthoid bodies, right? Amianthoid bodies are typical of intranodal palisaded myofibroblastomas, right? And what you see is pink, very bright, homogeneous material, which is dark, and with maybe you get a rim of lighter eosinophilic in the periphery. The word amianthus comes actually, it resembles fine, silky asbestos, right? And you see, this is the silky asbestos fibers, and it's likened to that, as though this is silky, and of course, it's eosinophilic, right? And that the parachrysolite um, asbestos, and it looks almost like that, sometimes it's slightly pinkish or almost the color of grapes, so it's like that. So this is what is amianthoid. Find this structure. Please note, these are not asbestos bodies because they are likened like asbestos. Asbestos bodies are, you can call them ferruginous bodies because they are these asbestos fibers on which you get encrustation of hemosiderin. You do a pearl stain and they are positive. So that's the ferruginous bodies. Now balloon cells. Obviously balloon cells means it's like a balloon which is enlarged, right? You can get a balloon cell nevus, you get ballooned hepatocytes, and many people, it actually means it's a very large cell, much larger than what you see normally. Their normal size. For example, in hepatocytes, many feel it should be at least 1.5 to 2 times the size, right? So that is balloons. The blastoma. The term blastos comes from sprouted germ. So therefore, it means it's quite primitive. They don't have any specific morphology. They have a very hyperchromatic cell, dark cell. It's almost like when in the blastomal stage of the embryo, you just take a section and see cells also look like this, absolutely without any differentiation. So some tumors were called blastomas. The terminology is changing. You have medulloblastoma, nephroblastoma, and so on and so forth, which are the primitive tumors. Use blastomas for those. Then coming to C, you come to columnar and cuboidal. Columnar and cuboidal, these are terms that are very often used. Please remember, in columnar, the height is more than the width. Whereas in cuboidal, it's like a cube, the height and width are almost identical, right? So, because the word columnar comes from pillar, cuboidal comes from Greek word for cube, okay? So this would be columnar cells, right? In the cervix, you see, these are height much more than the width, and you see these on the surface mesothelial cells. The width and the height are almost identical. So these would be cuboidal cells. These are the columnar cells, right? Now, cribriform. Well, any of the students who are with us, should I call their names or you will just answer like this?
You can call their
Okay.
names. Yeah, you can ask them call by name. Well,
Nirmal is not there.
or anyone.
Nirmal. Nirmal, can you hear me, Nirmal?
Yeah, sir, I can hear you.
Can you tell me from what cribriform means actually?
Sir, sieve like.
See, like, yeah, it's right. Okay. Anyway, this is cribriform. Cribriform means sieve like this. Is there in every household, and you can see. So you see, they are all uniform. The cribriform usually they are uniform. The cells are all uniform here. These punched out holes are some maybe little large or small, but by and large they're almost similar. Okay. Now they don't have any particular orientation to the nuclei, that they should be parallel or radiating or anything. It's as if they are punched out here and there. Now, the cribriform pattern is restricted generally to the reproductive system, breast, prostate, endometrium, and also the colon. And you should distinguish this from adenoid cystic, col-exner bodies, and so on and so forth, like in granulosa cell tumors. And look at the edge for adenoid cystic, as I told you earlier. Now here come to call and Exner, Emma Louis Call and Sigmund Exner. They described this. The German scientists, and they saw this in the sections from the ovary and described these call Exner bodies. Now in call Exner bodies, generally you get this eosinophilic material. Sometimes you get little strands of this eosinophilic thing going there, and all around you find these granulosa cells. They have a groove. Invariably you see these grooves, right? And they are arranged almost palisaded like this, as if there was a basement membrane here and they are radiating from this. That's the typical appearance that you can get in a col-exner body, like here what you're finding. And this is typical of certain tumors. We'll come to it. Next, we come to the famous Tom and Jerry thing. There's the Swiss cheese. And of course, this is nothing but cheese with these, which during the processing, you get a lot of gas bubbles that come out and give these rounded appearance, which are Some may be large, some may be small, and so on and so forth. So this is the Swiss cheese appearance in the endometrium, So earlier, in many cases of DUB, they used to ask what kind of endometrium do you get? The answer would be Swiss cheese. Now it's not as simple as that. Okay, so you see this? This is likened to these holes which are different, and you get an epithelial lining around all this. It's not stromal lining. Do you see this? Ovarian stroma, these ones, and they are of different sizes and shapes, just like the typical Swiss cheese. Right. Okay. Similar to that, you have, I don't know, they called it the honeycomb lung. It could be a Swiss cheese, but I guess the spaces were much more widened and almost uniform, because initially this was described in congenital bronchiectasis, where the dilated bronchi all over the lung gave it the appearance of what was called like almost like a honeycomb or a sponge. And they use different terms for this, like Waven lunge and Zasten lunge and Schwamm and sac means sacculated, spongy, cystic, honeycomb. But it was not used by Hamann and Rich for the end-stage lung disease, honeycomb lung that you describe, and it's all part of the Hamann and Rich syndrome. And it appeared much later in the English literature, much later after Hamann and Rich described it. So this is honeycomb lung. And you see, this is how the honeycomb looks like, right? So they have rigid walls here and almost identical size, but in reality you get a lot of stroma in between, some rigidity and these spaces. So this is almost typically used in the case of lungs, honeycomb lung. Then see, we come to the cobblestone appearance. Cobblestones are nothing but the paved path earlier, when we didn't have these tarred roads or concrete roads. They used to put small stones to ensure they're hard enough for the cart wheels to go. And actually, these kind of stones were smoothened, and they used to get smoothened because they were collected from the riverbed. And as the water flowed, they became rounded or called cobs. So they use these cobblestones for making roads and so on. So you have these stones, and then you have this ground in between. Okay, so that's the cobblestone appearance, typically seen in Crohn's disease. You see, these are the inflamed mucosa, and this is the relatively uninflamed. So it's not red. So you have, sometimes you have the inflamed mucosa, the ulcerated part or inflamed part, which is not raised. So raised and not raised, raised and not raised. In ulcerative, this is typical. They are much more rounded and seen typically in Crohn's disease. Okay, right? And there's the endoscopic appearance. It looks almost like this cobblestone. Then the word cluster, nest, or nidus, they all mean the same. It means an aggregate of cells or whatever it is. So the word clusters you generally use in cytology, and sometimes use in histopath when you get a small group of cells that lie almost little separate, cluster of cells, so on and so forth. And nest and nidus, of course, they're more compact, and you wouldn't call this a cluster. Yes, it's not loose actually, right? You can get call a nest of squamous cells or something like that, right? And so it's like this bunch of keys thrown, and this is a nest. Okay, so cluster and nest are used in those ways. Sometimes the word nidus is used a little more specifically. It refers to a small prominent part which is almost separate from the surrounding area, and it's relatively distinct. The best example would be the nidus in osteoid osteoma or osteoblastoma. In fact, this is one term that's used both by the radiologist and by the pathologist. You see, this is the nidus, and depending on the size, of course, 1 centimeter, so on and so forth, it helps in making the diagnosis. This is nidus. This looks separate from the surrounding area, right? So there you use the word nidus. Then come to the word crypt. Now there's a difference between villus and crypt. Crypt means something that is deep and going down. It comes from the um, literature where in churches you would have a basement that is very deep, and many a time tombs used to be kept there, tomb burial used to happen there. That's why you have all those horror movies earlier, tales of the crypt and so on and so forth. The ghosts used to arise from those buried from those tombs, deep down and come up. So that's the crypt. So anything that is deep, very deep, this is the surface, this is deep, that is crypt. Then you have the word bossylated, right? Now, what is bossylated? Bossylated means raised, embossed, okay? And it actually comes from the word hump or swelling. And actually, when you use the word bossylated, it refers to more than one hump, right, or protuberances. And it's generally used in a gross description, bossylated tumor. The word nodule or nodular means just like a nodule is a knot. That's comes from a small knot. It should be like this. No? So you see, this is nodular glomerulonephritis, nodular lymphoma. So it's like a not a small, distinct, rounded collection. Okay. So you can describe the small nodule in the lung and so on and so forth, multiple nodules. Now, the nodules can become confluent also. One nodule, two nodules becoming confluent in this nodular glomerulosclerosis. The other term similar to a nodule is lobulated. But the word lobulated means it has to have different lobes or parts that are almost or actually separate from each other, but connected or seem to be originating from one point, just like a clover leaf, They're all separate, but they seem to be joined at one point. Okay, so lobulations in gross will actually they look almost like bossylations, except that they're much smaller. So the word lobule should be used histologically in that context, and grossly when you say lobulated, they are actually smaller than the protuberances that you see in bosylation. Now there's no size for this, 1 centimeter, half centimeter, and so on. So this would be lobulated. It looks as if from this area there are these small, and they're small rounded areas. Almost, if somebody says this is a small bosylation, well, I guess nobody can argue with that. Now this is a lobule, you see. It all looks joined here, and there's small little nodular aggregates all around, right? So that's term used for lobules. Now then we come to discrete and confluent. Discrete means separate, whereas confluent means together, or actually like a confluence of rivers. They all tend to join and flow together. So that is confluent, right? So discrete will be separate, right? And confluent will be joined together. And in tuberculosis and all, when you find multiple giant cells, they're likely to be confluent because discrete granulomas initially originate with one giant cell system and they join together. But anyway, this This is sarcoidosis, discrete, tuberculosis is confluent, and so on. So, right? Dysplasia. Now, dysplasia is by and large is used to denote a precancerous or potentially cancerous, um, stage in the evolution of a cancer. So now the term dysplasia, dys means painful. It also means bad or disorder. So we use the term dysplasia in this context of its disordered, and placine means to form. So dysplasia means disordered growth. But then you see, it's not always cancerous. For example, developmental abnormalities such as renal dysplasia, right, are absolutely non-neoplastic. Fibrocystic disease of the breast, when we were students, they used to call it mammary dysplasia. It's now no longer used at all. Now, dysplasia, of course, otherwise is used in pre-cancerous formation, but nowadays, they have changed it to intraepithelial neoplasia and so on and so forth, right? So the term dysplasia is gradually maybe going to be uh, replaced by terms that are more specific, right? And so the word ATP, atypical hyperplasia, carcinoma in situ, intraepithelial neoplasia are all used almost synonymously, right? Some have been excluded from earlier classifications or WHO book. If you read, many of these earlier terms have been replaced by the newer terms. So dysplasia is still used sometimes in the GI tract, mild, moderate, severe dysplasia you can use. In cervix, of course, it depends. Some people still use it. Melanocytes and bone marrow, myelodysplastic syndrome is still used. Atypical hyperplasia, sometimes we use in urothelium, endometrium, but they're all being gradually replaced. And many have been replaced also. Atypia, vulva, respiratory tract, they were used, but they are being replaced. But of course, you have the carcinoma in situ still in place, intraepithelial neoplasia, an intraepithelial lesion like squamous intraepithelial lesion, and so on so forth, right? So they are all actually, all these terms were used interchangeably as far as precancerous lesions is concerned. You see, this is a renal dysplasia, absolutely benign, right? You're seeing it, okay? Then you can use dysplasia in a benign way, like fibrous dysplasia of the bone, osteofibrous dysplasia of the bone, and so on and so forth, right? And then, of course, in the way of precancerous or maybe lesions prior to formation of full-fledged cancer, that you can see in the cervix, right? So this is the endometrium and so on. So this is the word, and this is the lobular carcinoma in situ. This is also this is the ductal carcinoma in situ, DCIS, and so on and so forth. So these are used in that. Now the word dystrophy was originally used to describe some form of defect or faulty nutrition, trophy, nutrition. So because the nutrition is less, therefore these didn't grow. So, and that was typical of muscular dystrophy. You get small sized muscles, okay, muscle fibers, right, and almost replaced by fat and so on and so forth, right? So this is, but then in the vulva, the word vulvar dystrophy is used in different connotation. Right here, it is more an inflammatory lesion, and there's a spectrum of these vulvar dystrophic lesions right? Looking like lichen planus and so on. So that's dystrophy. Now the word epithelium, can anybody say, oh God, who is that? The next person, can you tell what epithelium means? Nisha is not the Jinal. Jinal or Seema? Anyone?
Protective barriers are lining.
Okay, it's a protective barrier. Well, okay, anyway, the word epithelium, epi means above, thelia means nipple. So it looks like as if something is above the nipple. Now, this was given by Rush when he examined the circumvallate papillae of the tongue. And he saw that these are nipple-like structures and there was something lining on top of it. So that he called it epithelium. And this was nothing but the squamous cells or squamous epithelium lining the circumvallate papillae. So now that was Rish many centuries ago. And then Henley, the loop of Henley, the same person, adopted this for all types of epithelium. So now it no longer need not be above a nipple-like structure. It can be flat anywhere, right? Right. So that is how the word epithelium. It's a mucosal lining anywhere inside is called the epithelium. Epithelium. Next, fibrinoid necrosis. Fibrinoid necrosis. Yeah. Yes. Who is next? Dharti or Aditya? Anyone? Aditya? What is fibrinoid necrosis? What it means?
It is seen in the vessels or
Is there necrosis actually?
immune complex deposition occur.
Yeah, it's actually a misnomer. There's no necrosis as such. There's no death of cells. It's more an encrustation of proteinaceous material, maybe fibrin also, and it looks like fibrin. So that is why it's called fibrinoid, means like fibrin. This typically seen fibrinoid necrosis seen in SLE in glomerulus. Then we come to fibrosis. Fibrosis means you have an excess of fibrous tissue. The word desmoplasia means actually, desmos means restrain, means hold back, right? And so plasia means forming, of course. So it means something that is holding back the cells. So that is called desmoplasia. And it's mainly fibrous tissue. It's not just hyalinized or homogeneous tissue. You generally get some fibroblasts, which you can see under HND. It's not absolutely hyalinized, rarely. And this is exemplified by the desmoplastic small round cell tumor, desmoplastic melanoma, desmoid tumor. Now you'll notice the word desmoplasia, you don't say fibrosis, right? This word desmoplasia is almost always restricted to tumors, whereas fibrosis is restricted to non-neoplastic lesions. There is fibrosis, and so on and so forth, retroperitoneal fibrosis, and so on and so forth. Okay, but whenever there is a tumor, more than fibrosis, you tend to use the word desmoplasia. The word sclerosis means hard, and the word sclerosis is generally used to, to mean that the fibrous tissue is so much that the tissue is likely to be hard. So this is called sclerosis. Okay, so scirrhus is generally used in a gross term, okay? And the word scirrhus comes from a hard tumor or callus. Callus is bony. So, so hard it should be. But anyway, the earlier invasive ductal carcinoma was often called scirrhus carcinoma of the breast, mainly because of the gross appearance. Okay, anything that is scirrhus means it is hard, is likely to have a lot of fibrous tissue. Okay. So the words clear, this scirrhus would be seen in the breast, it can be seen in stromal fibrosis, sclerosing adenosis, radial scar, and so on and so forth. Scirrhus carcinoma is invasive ductal carcinoma with, you can say, desmoplastic reaction. Okay, even radiologically and grossly you can see it. In breast, it is typically like this, hard whitish areas with, you'll find small chalky deposits, right? These chalky deposits are nothing, they are not chalk, calcium, but actually small foci of necrosis that you get. And if you see it carefully, you'll be able to make a nice gross diagnosis. And fibrosis, of course, I told mainly in benign bone marrow fibrosis, in pulmonary fibrosis, sometimes fibromatosis, you can use it. The word hyaline means it came from the word crystal or glass. So it should be very fine, smooth, and almost translucent. You get that feeling, and homogeneous, right? So it is a clear glassy substance. This is hyaline cartilage, right? And you see, this is the hyalinizing trabecular tumor. You can see this. This is homogeneous. You don't see the fibroblasts there in HND, unlike in desmoplasia. Okay. Keloid. Now the word keloid, because of its growth in the gross, it was first likened to keloidae or almost to cancroidae or cancer, and it's derived from the Greek word which means crab's pincers. And that was mainly the dermatologists and surgeons used it to show the scar that used to literally bite the individual and keep it there. Okay, but grossly, of course, you find this large areas of collagenization was parallel, okay? And when you do dermatopathology, one common question will be, how do you distinguish keloid from hypertrophic scar, and so on and so forth, right? And these would be more hyaline in appearance. And then, of course, you get this fibrous tissue. These would be more desmoid in appearance. Anyway, this is keloid. Then elastosis means increase in elastic tissue. Elastic tissue looks bluish and almost wavy. This is best seen in the skin of old age individuals or pseudoxanthoma elasticum. And anybody? Seema, you have not answered. Can you tell me what is the stain for elastic tissue?
Sir, bone,
Yeah, almost near here.
bone,
Anybody else?
Verhofstadt.
Yes, Verhoff's elastic stain. Okay. Seema, it is Van Giesen and Verhoff stain that they use. Elastic Van Giesen or VVG they use. Any other name? Do you think any other stain? Can anybody say for elastic tissue? Fine fibers you want to see. Anyway, you can do an Orsin stain, Orsin. That's also good enough for elastic tissue. Now, what is the difference between ectopic and hypertrophic? Okay, ectopic and heterotopic. Who will tell this? Jinal?
Ectopic means the tissue is located somewhere else from its original place.
Yeah, and heterotopic?
So
Eh? Anybody? Well, heterotopic, ectopic, they are not there in their original place, both of them. Okay? You have ectopic thyroid, heterotopic thyroid, so on and so forth. But you use the word ectopic when even in the original place it is not there. That means if there is an ectopic thyroid which is lingual, that means if you search the neck, you will not find the thyroid. You'll find it only there. If there is ectopic pregnancy in the ovary, it means the pregnancy is there, the fetus is there on the ovary. If you search in this actual place, which is the uterus, it will be empty. On the other hand, if it is heterotopic, like heterotopic gastric tissue in Meckel's diverticle, that is usually seen in the opening of the Meckel's diverticle. The gastric tissue is already there in the stomach. In addition, you have it in another place, that is in the Meckel's diverticle. Right? So endometriosis is almost like heterotopic endometrium. It is also there endometrium is there in the uterus. In addition, it is there in another place. Okay, I hope that is clear. So heterotopic thyroid means there is a thyroid in the neck as well as maybe in some other place in the neck. Another part is not distributed. Whereas ectopic means is there only in that place. So the importance of this clinically is, suppose there is a ectopic thyroid in the tongue and the surgeon removes the entire thing. So he has to um, replenish the hormones, right? So like that. Ectopic pancreas, it's there, but it's not there just beneath the splenic vein and in the duodenum. It's ectopic pancreas is there elsewhere. So that is ectopic. Okay. Now giant cells. Now giant cells could be physiological or pathological. Now in physiological you have osteoclast, syncytial trophoblast, megakaryocyte. Giant cells mean the cells are large. It may or may not have multiple nuclei, right? But generally they have multiple nuclei. Now physiological giant cells, generally the nuclei are multiple, they are small. But still you can get a lot of cytoplasm. They don't occupy, there's no high nuclear cytoplasmic ratio. Although there may be, in osteoclast, people have counted more than 100 nuclei, but even then you can make out it's an osteoclast. Okay? So, in the case of megakaryocytes, how many nuclei are there? Anyone? Any one of the 5 students who are there with us today? Can you tell? Dharti is there or Anupam is not there, no? Anupam and Nisha? They are
Yes,
not
sir.
there.
Anupam and Nisha is not there.
Dharti?
So from chat, we have some answers.
Yes.
Some people are saying multiple thousand. Someone is saying only one, but multilobated. This is the most common answer.
Who is saying one? Manisha.
Sir, yes, sir. Manisha and few others are saying one, but
Okay.
multilobulated.
Compliments to all of them. Yeah, it is actually uh, one nucleus that is multilobated and it gets cut across. Okay. And actually the DNA replicates. Okay. And then instead of the normal 32 copies, you can have 64 or multiples of 32. Right? And therefore, they become large, they become lobated, various pseudopodia like here, there, And when you see in a section, they look like multiple nuclei, right? So that is what. Pathological, you can get inflammation, foreign body giant cell, Langerhans, Anish-Cow in rheumatoid arthritis, Aschoff, two-tone giant cells. And what are these giant cells? Anybody? Anyone in the chat? They are called crouton giant cells. And where are they seen, crouton giant cells? Crouton giant cells are seen in cryptococcuses. Okay, anyway. In viral infections, you have herpetic giant cells, cytomegalovirus giant cells, Warthin-Fingaldi, and respiratory syncytial virus. Their cells are giant, but you see there's only one nucleus, cytomegalovirus. Tumors, osteoclastoma, of course, Reed-Sternberg cell, the classical one. Look at the size of the nuclei. Real alive, they're large nuclei compared to the physiological ones, right? Anaplastic tumor giant cell, and of course, rhabdomyoblast. Then others, you can have neonatal giant cell hepatitis, right? So they are giant cells with this multiple, 3 or more nuclei. Then you have muscle giant cells, right? So these are the other ones that you see. So you see, giant cells are numerous. They have different names, and you'll know about them later. So you can get inclusions in giant cells, asteroid bodies, Schumann bodies, which are calcifications. Okay, then you can get crystals. Sorry, in them, right? These oxalate crystals in giant cells, cholesterol crystals, and these are the Hamasaki symbol bodies which you can see. Glandular. The word glandular comes from the actually Latin glandula or gland of the throat or tonsil. And actually, this glandula came from the word from acorn or nut, which used to fall down. So they used to think that the secretion of glands used to go out. So it's like falling down from that. And they likened this acorn to that, and they called it glands. And please note here, the acorn has a resemblance to the another word which is similar to glands, that is the glans. And that's why you have the word glans, penis, okay? And it's a diminutive of the word glands. Okay, so this gland came from the word acorn, like that. To cast or something to be dropped. Now the word adenocarcinoma means all carcinomas which are from which have a glandular configuration. You can divide it further into tubal, ductal, acinar, or follicular, right? And if you find secretion, it may be acinar in origin, but very often it's not demonstrable at all. So it's by convention, different tumors are called, like in the case of breast, it's called ductal carcinoma, right? Pancreas, you can have acinar carcinoma. Thyroid, it's called follicular carcinoma, right? And so on and so forth. You can have. The word tubular means like a tube. So it should be of almost equal lumen throughout, around it, almost similar there. So that is a tube. So wherever you see, and generally you can get 2 layers of cells or 1 layer, whatever it is. They have a similar lumen all throughout. So that's roughly about that. You can't measure. So lobular means, like I told you, lobule. They're all separate but attached at one place, right? Whereas acinar more, much more. You have multiple lobules attached together like these small ones, and they form one bunch, and they are attached to here. So so in the breast, this is a terminal ductal lobular unit, and you get lobular carcinoma, right? And you have these acinar carcinoma in the pancreas, bunches here, there, like this, and all with a duct somewhere here in the center where they are attached, like almost like grapes, like this. So they are the terms. The ductal is like a canal, you can find it. Whereas follicular is like a bellow. This opening is so small, you cannot see it. So, for example, in the thyroid, it believed this secretion would go out of the follicle. So, how would it go out? There is a small little nozzle like this, you can't see. So, therefore, this is a follicle. Unlike a duct, you can see the milk will flow out like this. So, this is follicular. Similarly, they use the convention of hair follicle for this. If there's very small opening, but of course, why not a hair duct? It's also okay, right? There's no secretion. Follicle is also used in the case of the lymph node. These are follicles, primary and secondary follicles. Alveolar means a trough. It is a wide vessel, typically in the lung, and then you have alveolar soft parts. The type of glands, tubular, acinar, and alveolar. These are the two types, three types which is described. The type of secretion could be merocrine, right? In merocrine, the secretion goes out of the cell, nothing happens to the cell. Then this is apocrine, in which a little bit of the cytoplasm forms a collection around it, and you get snouts as they are going out. That is apocrine. And holocrine is in sebaceous glands. So what happens is the secretion is there and the entire thing goes out. So this is a holocrine gland. This is an apocrine gland, right? This is a merocrine or eccrine gland. Focal. Focal means it is a point of convergence. It comes from the Latin word for hearth or fireplace. Earlier in the West, where it's very cold, there would be a single fireplace and it would keep warm. The entire house would keep warm. Santa Claus coming down from there to the chimney, and the entire family would gather on the fireplace for talking to each other. There were no mobiles then, of course, and they used to chat. So, and family and friends would gather around the fireplace. So that is focal, right? So you have focal, right, or patchy in the case of inflammatory bowel disease, right? Focal increase or patchy increase. In kidney, focal means a part of a single glomerular here and there affected, whereas diffuse means all the glomeruli affected. Diffuse proliferative glomerulitis, focal glomerulonephritis, okay? Now, of course, in the kidney, if the entire portion of the glomerulus is affected, you call it global. If only a small portion of the glomerulus is affected, is segmental. So focal is used for number of glomeruli, focal and diffuse. Diffuse is nearly all, focal is one here and there, whereas global is used for the single glomerulus, whether it's affected in full or in part when it is segmented. So you can get a focal, segmental glomerulonephritis or glomerulosclerosis. You can get a diffuse, global glomerulonephritis, right? But generally, they are not used in this term, but this is for explanation. Whereas in focal or patchy in inflammatory bowel disease, focal increase means normal background inflammatory cells with increase here. Patchy increase means the background cells are also increased, and then you get suddenly some cluster of cells here and there. So this would be patchy increase. This is focal increase. So focal and patchy are used in this term. Granuloma comes from small grain, right? So that is it's used for a type of inflammatory reaction, right? Chronic inflammation. made up of epithelioid and histiocyte cells aggregated together. Hemangiopericytoma or hemangiopericytoma like pattern. You have tumors which are tightly packed with thin-walled vessels that have an antler-like shape. And you can get in hemangiopericytoma, synovial sarcoma, mesenchymal chondrosarcoma, fibrous histiocytoma, mesothelioma. Lot of tumors can have that, right? Now, see, this is the typical hemangiopericytoma appearance. You should get like these cells with the small cells, almost uniform elsewhere. And look at this tag on. Now, if you get just blood vessels with cells around them, like in Ewing sarcoma, the remaining portion becomes necrotic, it is called perithelial. There you don't get antler-like cells and so on, so forth, like shape of blood vessels. So this is perithelial. Hobnail, these are the nails in, see, army boots and all, so that when they stand in attention or stamp their feet or click together, they will get a sound. So it has a big head and a small portion which goes in. So this is the hobnail. The hobnail appearance, area Stella's reaction and so on and so forth. They made endometrium. The luminal part is large, enlarged. Usually the nucleus is located there, and you have a small portion, thinner portion down beneath, attached to the basement membrane. Lacunar. Lacuna means it's a blank portion. So that means lacunae in the literature, which you write when you're submitting a thesis, is there are certain things which are not there in the literature or missing in the literature. It comes from the word hole or a pit, So you have this word lacuna, right? And it came from, see, this word is used for lacunar infarcts. You can get the lacunar type of cells in Hodgkin's lymphoma and so on. So there is a space there. Basically, if you see a space, there's a lacuna here, okay, and these are lacunar infarcts and so on and so forth. Okay, so that's how you get lacuna. Medullary. Medullary means soft. In fact, they say there's a Sanskrit link to it from the word medhara. So any tumor that is grossly soft consistency is called medullary, and you can get it in thyroid and the breast. And the corresponding counterpart is called medullary carcinoma, right? So that's how you get medullary word. Now, what are these cells? Anybody? Any of the PGs? This is in thyroid.
Papillary.
Oh, yeah? Clear cells. What are they? Yeah, somebody's written orphan Annie. Who is orphan Annie?
Animation character.
Ah, yeah, Dr. Indranil has written. Yeah, orphan Annie was a little girl in a cartoon, Little Orphan Annie. It's a cartoon series, right? And the artist there was very peculiar. He never draw the pupil of any of these characters, especially Orphan Annie, you see. They just round circles, no pupil. This dark line is not. Even he had a little doggy as a friend. The doggy also didn't have this, right? So that is Orphan Annie. And please note, in the liver, you get like this. These are called glycogenated nuclei. In the liver, they are not called orphan Annie nuclei. They're called glycogenated. Orphan Annie is almost restricted to the papillary carcinoma of the thyroid. So this is glycogenated nuclei. In the liver, you get in diabetes, non-alcoholic fatty liver disease, Wilson's disease, and so on and so forth. So this is orphan Annie. Papillary. Papillary means finger-like, nipple teeth-like. Okay, and papillomatosis is almost like finger-like uh, configuration, and many people say that there shouldn't be a blood vessel there. A true papillary tumor will have a blood vessel. Papillomatosis will have only these cells. Right? So intraductal papillomatosis in the breast generally not find a fibrovascular core. Okay, this would be papillomatosis. This would be any of the papillary tumors with a fibrovascular core. Okay, some people call it epitheliosis and so on. Pearl. These are pearls. I need not go into the details. And look at this. Keratin pearls. They are likened to those pearls. You see, usually you should not see any nuclei, but of course, even if you get a world here, you will get that. Okay. Then perineural invasion. It's not true perineural, actually. Many people say perineural lymphatics. It's actually perineural space invasion. There's no lymphatic as such. Okay, so there's no prostatic adenocarcinoma, adenoid cystic carcinoma unknown. Phyllodes. Phyllodes means leaf-like, large leaf, succulent leaf, and this is the phyllodes appearance in the breast, phyllodes tumor, earlier called cystosarcoma phyllodes, and so on and so forth. Physaliferous. Physaliferous means bubble bearing, means it bears something inside and it looks like a soap bubble. So this is typical of chordoma, it's a bubbly or vacuolated appearance. Samoma bodies means grain-like, sand grain-like, small, small grains. So this is called samoma bodies, concentric with calcification here. Reticular. Reticular means net, mesh-like. So this is reticular. And they're almost geometric spaces like this. Okay. Plexiform is also means net-like, but it's not used simultaneously. Roman bridge. Roman bridge is used in DCI. Sometimes you get these rigid pillars with a bridge on top of that. This is very typical. The Roman bridges had this almost semicircular spaces for fluid to flow with thick, rigid pillars in between. This is typical and a line like that. The Chenab bridge, railway bridge, has got areas like this. Okay. Rosette. This, of course, you must have seen in conferences and big shot. It almost resembles a rose. And then you see, these are the rosettes in many of the churches where there's glass painting, beautiful artistry seen in many places. And it's used in both glandular and neural differentiation. And there are 4 types of rosettes. 2 have central lumen, which are called true rosettes. Bailey's true rosette in neuropath. No, one is flexnus or flexna intestinus with an empty lumen in retinoblastomas, and ependymal when they have cilia or certain small fibrils inside. So they are 2 with a central lumen, and 2 which don't have any distinct lumens are called Bailey's pseudorosettes. Homerite or neuroblastoma rosette, they have a tangle of neurofibrils in the center, not a space, right? And perivascular or glial vascular rosette in astrocytic and ependymal tumors, they have a central blood vessel, not a space. Okay, so you better not to use the word pseudo rosette. So true rosettes and this pseudo rosette with a vessel or not, right? Ependymal vessel, and this is the flexna of intestina, homerite, all these have got certain things in the lumen. So these are the different types of rosettes that have been described. See, homerite, there's no lumen as such, right? You can get these tangles here. This is an ependymal blastic rosette. You see, there's a lumen here. See this, right? Okay. These are the other rosettes you can get in all body-like things. And this is a cholestatic rosette in the liver where you get this bile here. And this is a hepatic rosette where there's no lumen here. So this would be almost a true one. This is not a true one in according to neuropaths. This is called a cholestatic rosette. This is called a hepatic rosette. Right? So Schiller-Duval bodies. Schiller-Duval bodies was described in the endodermal sinus of rats. Okay, and a rat and mouse placenta. So they described a labyrinth. There is a space here. They described an allantoic vessel. There is a vessel you see in this, and a yolk sac endoderm which is here. And this is replicated in the yolk sac tumors and other many of the germ cell tumors, right? And see this vessel. Okay. And please note, in a glomerulus also, you get a vessel, but right on top of the basement membrane, you'll find these cells. Okay, you'll find the epithelial cells, and you won't find these labyrinth-like spaces there. Signet ring cells. Now, signet ring, many people think it's wedding ring and so on, so forth. It is not that, right? It means signet ring. There is the intracellular mucin. The nucleus is pushed to one side, and it is not a wedding ring. It is the ring that form the insignia or signature of kings. You know, somebody used to write a letter, and the king would put some wax here and put a seal of his kingdom there, indicating that he has signed it. So that is the signet ring. It has a nice thick ring with something protruding out. So that is the signet ring, you see. Intracellular mucin is there in signet ring. Whereas in mucinous carcinomas, the mucin is extracellular, not here. Of course, you can get some extracellular mucins in signet ring carcinomas also. Spindle, this is the spindle used in weaving and other things, and it has a shape with both sides narrowed down. Fascicle. Fascicle is a bundle that just streams together like this. Okay? Right? So this is the fascicle in a plant, and you see this is a fascicle that is streaming together. This fascicle of spindle cells. Storiform. Storiform means storia or matting. Many people have some difficulty in this. It's called spoke wheel, pin wheel, gig wheel, and so on. So spiral nebula and like this. So it has to be rounded like this, almost like a mat. See, like this. It should be like this, like this, like this. So that is a whirl. And typically, you see, this is the best way to describe. This is called the cowlick. It's called the cowlick because the tongue of the cow, no, when it licks, it goes around like this. So it's called this. So this is what you get in dermatofibrosarcoma purpura, whirling. This is the whirling pattern that you should see, right? Storiform, whirl-like. And this is the cartwheel that is seen typically in plasma cells. So these are the different patterns that you get. Herringbone. Herring is a fish, and it has spine, and the bones are parallel to each other, almost symmetrical on either side of the spine. So if you get like this pattern, this is the herringbone pattern in textiles. This is the herringbone pattern in tiles, and this is the herringbone pattern in some of the tumors, right? Should be like this. Squamous. Squamous means on the surface you get this scales like that of a fish. So this is how it's been likened to. So this is the squamous epithelium, very tight with each other. Okay, and they form almost a sheet which covers the mucosa, just like the scales of a fish or a serpent. Lepidic, right? Lepidic means along the alveoli or space, you have something growing. That is called lepidic, right? And you have this lepidic carcinoma, and it means scale-like flat superficial surface growth, right? And you have the lepidic carcinomas in the lung, right? You have bronchoalveolar carcinomas. They are called lepidic because they seem to grow along the alveoli. Trabeculate. Trabecular means a beam. Now the beam that you can see in any building, and the trabecular pattern can be further classified into insular if it is rounded, like in carcinoids and granulosa cell. Okay, and in trabecular arrangement, so beam-like means tumor cells separated by stroma or fibrosis. Right? So it can be insular if it is rounded, festoon, if it is serpentine or undulating, right? Like in carcinoid tumors, plexiform if it is anastomosing, which you can get blood vessels in liposarcomas. Right? In hepatocellular carcinomas, because the trabeculae have got blood on either side, it's almost called sinusoidal pattern. So you have different pattern: insular, festoon, plexiform, and sinusoidal, as far as trabeculae are concerned. So this is the trabecular beam, insular or island-like insular carcinoma you can get like this, or it can be festoon, like festival festoons like this, like you see, or it could be network or reticular appearance. So these trabeculae have formed a meshwork or network. So these are the terms that are used. Plexiform, see this? Plexiform carcinoma, you can see this, right? And this was used even grossly for plexiform neurofibromatosis, right? Because they seem to be forming a mesh or network like this thing, joining, anastomosing. You see this? Almost, this is a plexiform pattern of the hair, and this is a tumor that is plexiform. Indian file. Indian file means, see, if the second person puts his foot on top of this, it looks as if one person has walked. So that is Indian file. Many will be walking, but it looks like one person walked. And that is possible if you walk in line and put your steps exactly where the person in front put in front of you. On the other hand, if you each one puts their foot here and there, you will know that many people have traveled. And that's how the Red Indians camouflage the number of people walking. See this? It looks as if one person, but at least 50 of them would have moved. And you see, like this. So this is the Indian file appearance. And so if the tumors are single cell and aligned in a line, you call it then Indian file appearance. Here and there you may find 2 or 3. They don't follow. They never asked us whether lobular carcinoma, whether we should be in Indian file or not. So, but by and large, they'll be like this. That is the typical Indian file. Palisade means like a fence. So the cells are parallel to each other. This is the palisaded fence, picket fence. This would be a palisade of columnar cells. Palisaded appearance. Columnar cells arranged in a palisade. Villus means tuft of hair. Exactly like this. And that is how the villus. So it is raised above the surface, unlike the crypt, which is below the surface. So this is the villus. So you can get villus adenomas and so on and so forth, likened to the villus. Zelbalin. Zelbalin is a small nest of cells. Okay. So, and that is It's reserved for certain tumors. Zellballen pattern. Group of cells, you have blood vessels here, enclosing them, almost like this. Okay, small clusters. So with that Z, we finished many of these common terminologies. Immunohistochemistry, you can get nuclear or cytoplasmic staining, right? Or you can get the membranous staining on the surface. Generally, it's a mixture, it's a combination of these, either cytoplasmic, nuclear, or membranous on the surface. Okay. So depending on this, you can classify it, whether it's cytoplasmic, nuclear, and so on. So diffuse, membranous, granular, punctate or dot-like, and little larger one would be a targetoid appearance, right? So certain things like your transcription factors, steroid hormones, proliferation markers, core antigen, and S100 are all nuclear. All transcription factors are nuclear because naturally that is how they are, right? There are many tumors that many antibodies that give cytoplasmic. S100, calretinine, beta catenin are combined nuclear and cytoplasmic. Okay, you can get punctate dot-like. You see, go to CD30 staining and some other staining, you will find this. Okay, so intermediate filaments, contractile protein, secretory protein, melanosome, and other functional proteins are diffuse cytoplasm. Most CDs are membranous. Okay, adhesion molecules are membranous. Surface receptors, EGFR, RT2 are all membranous. Now, in the diffuse granular ones are mainly mitochondrial peroxisomal racemase, Golgi ones, lysosomal ones. Punctate dot-like, you get in neuroendocrine carcinomas, small cell carcinomas, pan-CK, Merkel cell tumors, CK20, ALCL, and classical Hodgkin's, this. And targetoid, that is the ball and chain appearance. You see this? The membrane is there, plus this. Classical is ALCL CD30 and Hodgkin's CD50. So this you will know. Then the word ambiguous means unclear. Ambi means two. Ambidextrous. Both hands you can use. So on and so forth. So don't be ambiguous in your histopath reporting. Right? So it'll have different clinical details, cytobiopsy, diagnosis, clinical gross and microscopy, and so on and so forth. And you can write a comment. Right. So it should be clear, concise, informative, and all the elements for a clinical decision. No need of writing flowery language and not conveying anything to the clinician, because you are a part of the management team. So therefore, your language must be such it should tell the clinician something, and you should tell whether it's valid or not. And of course, the report should be easily available and so on. So, okay, it could be a narrative reporting when you tell. A synoptic means you just fill in the blanks like that, right? So, for example, this is a chronic hepatitis, HCV etiology, which must be by clinical history. You give the grade, you give the stage, and the clinician doesn't want anything more, right? You can write a description and so on and so forth, right? Or you can give it is cirrhosis with moderate necroinflammatory activity. Instead of writing staging is 6, no? If you give this line, it helps the clinician much more in understanding. Otherwise, you'll have to look up what is stage 6. Of course, one who handles patients regularly will know, but a little bit of description will help him. So this is how you do. And they use various terms: diagnostic, characteristic, represents, appearances, typical of, indicative, that of, shows of, consistent with. So the percentage of confirmation is more when it is diagnostic or characteristic or represent, and so on and so forth. These are some of the studies people say. And when you write could be, equivocal, not excluded, risk of, and so on and so forth, apparently the confirmation is very little. So, and please note that very often pathologists write not excluded almost. Oh, can some pathologists say I write it 20% of the time? Suggestive of, the confirmation is only 15 to 20%. Almost one third pathologists may use that term very commonly. Shows, many use, and so on and so forth. You will note that diagnostic of, only about 3/4 use, and that's the best we can have. Right? So try to use the proper word whenever you do it. So definitive terms are these. Non-definitive, in keeping with, consistent with, highly suggestive of, favor, means it's not definite, you favor one over the other. And uncertainty means you write something and this. Okay. So, and this, so you see this, many pathologists have used many terms, and worrisome for, uncertain for, please avoid those terms. Okay. Otherwise, you seek second opinion from someone. There's no easy, that's what this doctor is telling. There's no easy way I can tell you this, so I'm sending you to someone who can. So pass on the buck to someone. Now the other terms, small terms, salmon pink, seen in amyloid, congruent staining. Salmon pink is not actually pink. It's little orangish, and that's the flesh of the salmon fish. That's why it's called salmon pink. You'll notice most of these terminologies made by medical people are related to food because they never had food in time. So this is called salmon pink, and this is Congo red. Please remember that stain Congo red has nothing to do with Congo. It was made in Germany. They use the word Congo because it was then a fashion. If you use some African name in this, people think it's something big. Okay. Apple green birefringence. The birefringence, once it is salmon pink, then you do birefringence. So after that fish, you have nice two apples, which are apple green. Okay. So that is apple green birefringence. Here's the color. So birefringence and dichroism are two different things. Birefringence is the double refraction, and dichroism is the color that gives there. Okay. Miliary tuberculosis. The lesions
Yeah.
are small in X-ray. They are like millet seeds. Okay. So that is the one. Stools. You can get butter stools in steatorrhea, fatty stools when there's excess fat, current jelly stool. This is the current. This is the current jelly in, of course, intersusception, and rice water stools, which is rice water which we throw away every day almost while cooking rice, that you get in cholera. So even the stools are like food. Spinach stools, dark green. This is in intestinal hurry, you can get pea soup. This is the pea soup. This is what you get in typhoid. And sago grain in amoebic diarrhea. Sabudana. This is this amoebic dysentery, you get that. Fish, of course, you have anchovy sauce, pus in amoebic, and fish flesh appearance in sarcomas. Right? Then you have mitral stenosis, which could be a buttonhole, right? Or a fish mouth. Right? So this would be a buttonhole, rounded ones, whereas this looks exactly like a fish mouth. They're so good in describing. A cut cabbage appearance, right? You can see in fibroadenoma of the breast, benign hyperplasia or nodular hyperplasia of prostate. Then you have the cauliflower appearance in proliferative growths, right? Then vegetable onion peel appearance you get in primary sclerosing cholangitis in the X-rays of Ewing sarcoma. Sago spleen you get in amyloidosis of the spleen. Bread and butter pericarditis is nothing but two slices of bread, lot of butter put in, and then you just remove them. So you get these little wisps of butter coming out. That is typical of pericarditis, fibrinous pericarditis. And prototype was rheumatic heart disease earlier. You can get in any fibrinous pericarditis, right? Fruits, you have strawberry gallbladder, looks like the surface of gallbladder, pitted. Only thing that is red, this is green. Then prune belly. These prunes are, shriveled and shrunken like things you get. And this is what you get, the prune belly syndrome in children. The belly is like that. Fruits, you have berry aneurysms and purity orange. That is the pitted appearance because of the lymphatics being full of tumors. They get a little raised. There's a lymphatic obstruction and so on and so forth. So you get this appearance where the hair and other things are. It is tethered down. Elsewhere it is raised, just like the surface. Watery-eye tumor like grapes, right? You know this. You can get in membrane rhabdomyosarcomas bladder and so on and so forth. Hydatiniform mole. This is a hydrated or drop of water. So clear, absolutely similar things you get in the uterus. Spices, salt and pepper nucleus. Small chromatin. Right? You get and nutmeg liver. Nutmeg is jaifal. Any person cooking biryanis will use this. This is when you cut the nutmeg, it's like a supari, you have this dark and light areas. This is nutmeg areas in passive venous congestion of the liver. Coffee beans, no marks, granulosa cell tumor. You see this? Beautiful coffee bean. Right? Coffee ground vomiters. When there is blood in the foregut. Okay, because of hemosiderin. Mutton and chicken, of course. You have chicken fat, post-mortem, the fat, and then the leg of mutton appearance. Exactly what you get leg of mutton appearance, you get that in osteosarcoma. Right? In fact, it was the leg of mutton appearance of dresses also they used to make at that time when women of of the higher strata of society used to wear these kind of clothes. That is, one part is enlarged and the rest is narrow. That is the leg of mutton appearance. Now, can you tell me the other name of sickle cell? Burr cell, spur cell. You see, elliptocyte means it's like an ellipse. Spherocyte means it is round like a sphere without the central pallor. Stomatocyte means there is the pallor is of the arrangement like a mouth, stoma. Schistocytes means this fragmented. This comes from the word schisto means which means to divide or cut. Teardrop, of course, is just like a teardrop. And sickle cell is this. This is a burr cell. Burr cell have got almost equal amount of protuberances, just slightly blunt, and they are almost equal. Whereas spur cells, they have sharp spinous processes which are irregular. And target cells, central dark area, you have a lighter area and then again a darker. Do you know the names of these cells, other names? Anyone? For sickle cell, for target cell? Anybody can tell? This is the last slide.
Teardrop cells for dacrocytes.
Very good. Dacros means tears. Okay, then
A target cell, podocytes.
Podocyte. Codo means bell. See
Well,
this? Space, this space, and then the bell surface. Exactly like. Okay. Drepanocyte for sickle cell. Drepan means a sickle. Echinocyte for burr cell. Echinos means it comes from the sea urchin or hedgehog, right? Although they are quite sharp, but the burr cell is not that sharp. They're equal. Spur cell, acanthocyte are unequal. Very good, right? In fact, this is the Echinococcus family. Very good. So you must reflect, or you can imitate someone. That is the easiest way. But the best way is by experience. So keep seeing slides, talking to people, and reading books and gathering experience. And don't miss. In this doesn't mean that you are not posted in somewhere. You'll not see a specimen or slide or anything. Keep doing it and do it with your own hands. Then you learn all these words better. The more you come to use it, the better it will be. So thank you very much. So it's been a long day and I hope you have learned some of these words. Thank you so much. Any questions, anything?
Thank you, Siddharth. I think this was a real treat to go from A to Z. You didn't have anything in Z, Siddharth.
Zelbalan, ma'am.
Oh, did I miss it? I don't know, perhaps. Did you say Zelbalan?
Yes,
Yes,
ma'am.
Oh,
ma'am.
you did. Okay. So it was really from A to Z. I must have missed it somewhere because I was on the phone. So really, it is truly a treat. It's the A to Z of pathology, so to speak. So I don't know. Are there any questions in the?
No, ma'am, no questions, but there was a good participation in the chat box also.
Oh, that's very good. I think lots of people have answered questions in the. I see one question over here from somebody called Sankar, and it is, what is an organoid pattern?
I think, ma'am, meanwhile, sir had explained it in the.
Oh, okay.
Ma'am, you're going to talk on
Yes, I'm going
patterns
to
also,
talk
no,
about
tomorrow.
patterns, and there's inevitably going to be some degree of
Or
overlap.
yes, yes.
But that I will do. Yes, the next talk, that is on Tuesday.
And anything else?
Any
Okay.
other questions? I think what you said at the end is absolutely right. You have to, when this is like learning a language, and unless you can't learn a language by learning a dictionary. No, you don't take a dictionary and learn a language. You learn a language by using a language. Of course, you have to learn the words, you have to learn the grammar, and then you have to use it, because unless you actually put it into practice, you won't know whether you are understanding or being understood. And the real reason for learning a language is that to understand what other speakers or writers of the language mean, and when you are speaking it, whether other people understand it in the way that the language is spoken. So I think that you're right, Siddharth, that they will only, I mean, people who are just learning this language, it may be confusing in the beginning, but by using it, by constantly refreshing, their use of it, also making observations, making interpretations, I think is the way to go.
Yeah, and the more reports they write, they'll improve their
Yes. You're right.
The way how they communicate with the clinician. That's very important.
It is. And I am a little unhappy about the way that people frame reports these
Yes.
days, because I think that people think that it doesn't matter. I've reached the right diagnosis, so what does it matter what I write in a report? And quite often, yes, we do reach the right diagnosis because we're matching pictures in our head, and it cannot be anything else but that. And something even worse than that is you have reached the diagnosis, say, of granulomatous lymphadenitis, and you don't even bother to write a description if you wanted to write a description. And there are descriptions that that are there, yeah, with your typist, and people say granulomatous lymphadenitis, and the typist types out a description. It's happening all the time that you are using idealized descriptions to describe what you have made. And sometimes it's so amusing, if it is not tragic, when you think that it is tuberculosis or a granulomatous lymphadenitis, but actually it is not. It is something else, and there has been an idealized description that has, if you read that description, it can't be anything else but tuberculosis. But if you see the slide, it is anything else but tuberculosis. And this is becoming more and more common, because I'm in the position of seeing, and I'm sure many of you are, in the position of doing second opinion work. And you see that the description matches the diagnosis, but the diagnosis is not what it is in the slide. So
Yes.
I think that I think both things, just writing any old description to, once you have made up your mind what the diagnosis is not right. And at the same time, using idealized descriptive texts to, because it's too much to write a description.
Rightly said, ma'am. Another habit is that, ma'am, now the residents ask the consultant to give the dictation. Even that is not correct. They should bring with the description what they felt the slide looked like, and as to be corrected by the consultant at the time of reporting.
Yeah, that's ideal. That's true.
Yes,
But
I
they-
agree.
And I
they-
think all residents, sometimes they get scared. You must be, you must accept the fact that all of us make mistakes, whatever age it is. So you don't have to be scared in the beginning. And the more you do these things, hopefully the number of mistakes will reduce as you progress
Yes,
a little
absolutely.
late. And in fact, ma'am, there's a nice saying by a radiotherapist, Oscar Rambo. He said that a perverse sense prevails among clinicians that a pathologist given a piece of or sample of tissue has all the ingredients necessary to make the right diagnosis. Even more dangerous to mankind and society is a pathologist with the same concept.
Yes, I know. Of course, clinicians and others are very happy to poke fun and so on as at pathologists, and I think sometimes we bring that upon ourselves.
That's exactly what I'm saying.
Yes,
We shouldn't bring any of these things to
yes,
them.
that's true. You know what I have found is a very good way of making getting used to describing things and making observations, etc., is by sitting across a microscope. I mean, it doesn't have to be a double-headed microscope or whatever, but you are looking at something under the microscope, and you describe it to
Yes.
somebody who hasn't seen the slide. And if your description is good, your description, okay, not your final diagnosis, but if your description is good, the other person should be able to make a diagnosis. And if you have a friend or you have a group of people, you know, together, and if every day in turn somebody does 1 or 2 slides, describes it to the group and or to your friend or whoever it is, and they can make the diagnosis, it means
Yes,
that
ma'am.
your description, your observations, your interpretations are really good.
Ma'am, you're absolutely right. My professor of medicine once told us there was a case of ascites. He said that I'm not bothered about the diagnosis. You describe it. The abdomen is distended, flanks are full, and all that. And supposing you send it by post to someone about miles away, he reads it and he should send you back the diagnosis. Exactly what you're saying, ma'am.
Exactly. And I think that you can practice this every day. Everybody's sitting in a room because we don't have so much space. 3, 4 people are occupying a room together. This is just an easy way to practice your descriptive talents or whatever that you do. I found it a very, very sort of good things. I tell people that, if your description, if you do a very good description, then somebody like me who has seen, I don't know, hundreds and thousands of slides, should be able, from your description, even if I've lost my sight, I should be able to practice pathology because you are so good at making a description. Because sometimes people even call you up and describe a slide on the phone and say, do you think, what do you think? And sometimes they're doing such a good description that you can tell them, I think this is what it is. So I think that all of the students should do that. And another important reason, and that's why I think Siddharth was actually showing you pictures of not only the histology, but why the histology has come to have a name, is because a name, any name, triggers a thought. Even the name of somebody who if somebody says a name, it triggers a thought. And triggering a thought, so if you say the word, for instance, fascicle, okay, it immediately triggers a thought, and you can see in your mind's eye what that particular structure is. And I think that's important, because then your mind goes in the direction of what are these things that have fascicles, and you don't have to sort of conjure up a whole dictionary of words. You have got one word, it triggers a thought. So please try to use a language in the way that it was meant to be used.
And two things. One is, pathologists and perhaps radiologists to a lesser extent are these two who give printed reports, which are written to, to the clinician. Very few, even clinicians, they may write in the case sheet few lines and then go away. But such detailed things to explain to somebody what it is, and no need of writing everything big, but it should convey to the clinician what is required, because you are a part of the management team. If you leave it at diagnosis and finish off, nowadays it's not enough actually. So that's what ma'am is saying. No, you keep doing it time and again, refine more and more, refine yourself, and that's how you'll improve.
Right. Thank you, sir. Honk you for amazing class, sir. Thank you, ma'am,
I
for the
must
inputs.
thank you all, and I hope everybody learned
Yes.
something. And it was an honor to be with ma'am.
Come on now,
Yeah.
Siddharth. It's a mutual admiration society, if you ask
No,
me.
no, it's not.
Anyway,
Thank you, all of you.
I want to thank you, Siddharth, because it brings everything down to some fundamentals without which I don't think we can really build a whole edifice. If your fundamentals are weak, then the edifice is not going to stand for long. We're having too many building collapses and things in our country because we just don't think about strong fundamentals. So I'm very glad, and I think we invite you year after year to be with us because of the fact that you understand the fundamentals so well and you're able to communicate them to others, who are listening maybe for the first time to things that they have heard, but they have not quite understood. So thank you really,
Thank you, ma'am.
Siddharth, and
Thank
please
you.
do come again whenever
No,
we
sure.
invite you. And I
Pleasure.
have to thank the moderators,
Moderators.
Sakshi and Bonita, and all the students. Okay.
Thank you, ma'am.
Thank
Thank
you,
you,
ma'am.
students.
Today. Thank
Thanks
you
a
very
lot.
much, because through your answers, through your understanding, I think the others who are in the audience are, get to understand some things that otherwise they would not. And I want to thank Ruchi, because Ruchi is always here till the bitter
Oh my
end.
God. Yes.
So thank you very much, Ruchi.
Thank
Thanks,
you,
ma'am.
Ruchi.
Thanks,
Thank
thanks,
you,
Thank you,
sir.
Ruchi.
Okay.
And all the 5 students also. Thank you.
Yes, I thank
Yes.
them,
Thank you,
because
sir.
otherwise, as I
And the
said,
participants, of course.
Yes.
Thank
Thanks.
you, everyone.
Yes.
And I
Thank you,
would
ma'am.
like to
lovely.
invite everybody for
Sakshi
the
and
next
Bonita.
Tuesday meet. And I request the students also to be present in the next class also. That will be continuation of today, what we learned. That will be like being more deep into the patterns.
Yes, so it's about the language. That's basically, these two talks are on language. You have to learn the words, and you'll have to learn the grammar of how we use these words. Yeah. Okay. Bye then.
Thank you.
Thank you.
Bye.
Good
Thank you.
night.
Bye,
Thank you,
bye,
sir.
ma'am. Good
Thank
night.
you, ma'am.
Good night. Good night.
Good night.
Right.
Good night.